Hi guys, so I'm doing a little bit of studying tonight, just going through some anatomy. Like I said, I'm on A service right now, so I'm doing a lot of work with the colorectal surgeons. Figured I'd kind of go back through and refresh myself on some of that anatomy. When I'm studying anatomy, it kind of helps me to draw it out. I don't really do well with a lot of words, and a lot of descriptions and stuff. I kind of need to see it, so in the past, in my anatomy courses and stuff, just kind of drawing everything out really sort of helped me. So I'm gonna try to do that here. I have this kind of rigged up where my camera's on a mount, and I'm gonna be drawing in front of it. So it might work, it might not, but I'm gonna try to give it a go. So I think the easiest way to start this is just gonna be to sort of draw. Kind of start with the organs that we're talking about. So when we're talking about colorectal surgery, we're basically talking about our large intestine all the way kind of until the exit. So kind of bear with me here. I'm not much of an artist, but and so kind of at this point here is where our colon really starts. This is the cecum, and we're gonna kind of follow it up and around. This sort of hangs across midline. Obviously this isn't perfect, so kind of knowing what the anatomy is supposed to be and kind of supposed to look like really helps. Really helps when you're in a procedure because it's very rarely actually kind of positioned how it's supposed to be. So, and this is sort of not my best, but we're gonna try here. We're gonna see what we can do. And so I thought kind of a good thing to do, and this is kind of more than anything sort of helping me sort of kind of keep track of where I'm at. And it's actually probably should end more like right here, but for simplicity's sake, we'll go with that. So this is, the start of our colon. We have our cecum here, and then kind of down along here we have a little bit of an appendage. This is our appendix, roughly where it usually sits. And then right about here, this is the point where our large bowel connects to our small bowel. This is the ileum, your terminal ileum, and this is your ICJ right here, your ileocecal junction. Like I said, this is our cecum. This is the beginning point of our large intestine. We then have an ascending colon here at the point of what's called the hepatic flexure. Your liver's sitting right about here, so it makes sense. Hepatic liver. That's kind of where your colon takes a turn. Transverse colon, right over here. We have the splenic flexure. This is where your spleen sits, and then it turns into your descending colon, sigmoid colon, and then the rectum, and then finally the anus, obviously. A lot of this is really basic anatomy terminology. So, like I said, I kind of intended these videos to be medical and non-medical friendly. So, just kind of trying to go through the basics. The big part of it, and kind of the part that I'm really trying to get to, is when we talk about the anatomy breakdown, especially operatively, we want to look at blood supply. And so right down through here, this is kind of where we have our our abdominal aorta, right? So we have a really large vessel that kind of runs parallel to our spine, all the way from the aortic knob up here where it comes off the heart, all the way down through. It sort of splits right down here into common iliacs. these kind of split again, but we'll talk about that in a little bit. So right about here on your abdominal aorta, you have two major branches. So you have an SMA, right? So we have one branch that comes off here, right? And then we have another branch that kind of comes off right here. This is your IMA. SMA is your superior mesenteric artery. SMA. And then your IMA, your inferior mesenteric artery. So these two arteries supply blood to pretty much your entire colon. I'm going to kind of try to go through this. Like I said, this isn't going to be perfect at all, but basically your colon's kind of perfused or supplied with blood the whole way along. Different branches that kind of branch out along here. Kind of the whole way along the transverse colon. Descending. My sigmoid's terrible. This is actually kind of should be a little bit further over this way. Yeah, but I'll label all that. But essentially what we have is just these smaller vessels that kind of work our whole way around and perfuse our colon. And they sit in kind of a meshwork of loops, right? So we have kind of these loops of vasculature that sort of run in chains. And they're kind of suspended, right? They're suspended in this fatty kind of flap called your omentum that kind of keeps everything sort of organized as this is all sort of free-floating in your gut. And so then this SMA shoots off branches here, right? And so right here, this set of branches right here, it's perfusing like where the ileum's at, right? And so we're going to call this portion right here the ileocolic artery. And kind of as we move up, now we describe these not based on what part of the colon we're perfusing, but what side of the body's being perfused. So here, this kind of section right here is what we're going to label our right. Our right colic artery. And that kind of continues through most of this region up here. And remember, this is all coming off of our superior mesenteric artery. And again, we have branches then that are kind of coming up here through this meshwork, perfusing pretty much all the way across here. And everything that's being perfused here is what we're going to call our middle colic artery. By the way, side note, I definitely stole this pen from one of the offices at the hospital. It's really, really nice. I'm a fan. And so now at this point, we've kind of covered everything that our SMA feeds blood to. Now our IMA kind of does the same thing, but we're sort of working on the left side of the body now. So we're offering perfusion to what is collectively going to be called our left colic artery. We're also offering perfusion down here now at this point, right? My absolutely poorly drawn sigmoid colon, but this is what we're going to call the sigmoid down here. And so then everything being perfused here is collectively what we're going to call our sigmoid artery. Then after our sigmoid, we're working directly into the rectum. Now the rectum's a little bit different. So let's see, this might be better if I draw it. This is kind of, sort of, a little bit what a rectum looks like. And it's actually being perfused at 3 different levels. Right, so the top part of our rectum, so when we come over here, we're talking about this part. We're still getting blood flow from the IMA, from our inferior mesenteric artery. And those are what we call our superior rectal arteries. They're also called superior hemorrhoidal arteries, and I'll actually I'll touch on that a little bit more in a second, because that leads me into one of the procedures that we touched on the other day. And like I said, those vessels are coming directly off the IMA. So these are representative of coming off of right here. Now these ones are a little different. So we actually get perfusion at this level, and we get perfusion down at this level. And so we come over here, now we're talking here and ultimately here, right? So here we have our middle rectal arteries, or middle hemorrhoidal arteries, and then we have our inferior rectal arteries, or inferior hemorrhoidal arteries. So now, these 2 sets of arteries right here, our middle and our inferior rectal, or our middle or inferior hemorrhoidal, do not get supplied by the inferior mesenteric artery. Rather, when we come down here, so we're following our abdominal aorta down, that bifurcates into our common iliac arteries. Now, down here, our common iliacs, actually, they bifurcate again. And that bifurcation isn't really, isn't even. You get kind of a larger bifurcation that we call our external iliac, and then the smaller bifurcation here is what we call our internal iliac arteries. Right? And so those internal iliac arteries really only have 2 major branches, that come off of them, and that would be these guys. So your middle and your inferior hemorrhoidal arteries come off of the internal iliacs, and those are ultimately what offers perfusion to the middle and then the distal portions of the rectum. The reason I mentioned the procedure earlier was because these arteries right here, your superior, middle, and inferior hemorrhoidal arteries, are what are responsible for internal hemorrhoids. Internal hemorrhoids aren't painful. Most patients just kind of present with bloody stools, and the ones that are painful are actually a little bit further down. They're called external hemorrhoids, and those are actually the product of engorged venous blood rather than arterial blood. So here we're talking about arterial blood, and there is a cool procedure, one that I was actually in on with one of the surgeons on Friday, called a hemorrhoid artery ligation, where essentially the surgeon gains access to these arteries, visualizes them, and then actually throws a suture through here and ties them off. So these arteries kind of get blockaded, and eventually they sort of necrose and die, and that's actually a super effective way of preventing future complications from internal hemorrhoids. So that was a pretty cool procedure that I got to experience. What else? So nervous supply. So we talk about innervation too, of the bowel. Usually the nerves kind of help with bowel motility mostly. So innervation gets really complicated, and without being too talky and wordy, essentially off kind of the middle part of our spine, we get branches called splanchnic nerves. We have greater, lesser, and lumbar splanchnic nerves that sort of innervate this portion of the colon, essentially. So it gets a little hairy, but for the most part, our colon from cecum all the way down to sigmoid are innervated by these greater, lesser, and then lumbar splanchnic nerves. Once we get down to the level of the rectum, we have a little bit different innervation that those come from both hypogastric nerves, which is actually a structure that we need to sort of watch out for when we're doing a colon resection. Oftentimes they're damaged, but if we are careful, they are nerves that can be preserved during that sort of procedure with resection of a distal colon. And we also have innervation here from pelvic splanchnic nerves. So as we're working our way down the spine, we're at the level of greater, middle, lesser, and then pelvic splanchnic nerves. So we're working in like middle end of the thoracic, down through the lumbar spine, down into the sort of the sacrum, and that's where those nerve roots sort of shoot off. We also have innervation from the pudendal nerve. The pudendal nerve supplies sensory function to the rectum and also provides the only somatic. So when we talk somatic, we're talking about voluntary muscle control. Provides the only voluntary muscular control kind of in the large bowel, and that's the external anal sphincter. So, it's kind of a short, easy layman's rundown of the vasculature and kind of organ positioning of the colorectal region of the body. Kind of something that you can sort of see from this really poor drawing. When we are looking at these structures laparoscopically, so a lot of procedures that we'll do aren't really open anymore. We get port access into the abdomen. We go in with a camera and several other small ports that the surgeon uses to manipulate instruments in the abdominal cavity to do the work. Patients recover better, quicker, less room for error and complication. But one of the downfalls is you only have views of certain parts of the abdominal cavity all at once. So that being said, it doesn't ever look this nice when you have a camera in there. Not that this looks nice, but it gets really confusing because in front of all this you have feet and feet and feet of twisted and turned small bowel. So this guy, where your ilium's at, like we were talking earlier, connects into here, and this just loops and twists and covers and obstructs vision and makes it difficult to work in there. So a lot of times it can actually be difficult to distinguish large bowel from small bowel when you're looking at something laparoscopically like that. So there's a couple different things you can look at. One of them is these little pouches that I drew. These are called Haustrae. They're points of vascularization along the large bowel, and they're also points of motility or bowel peristalsis. not all that easy to identify visually. It's a little bit more easy to see these on imaging. So when we get a CAT scan of the abdomen or CT scan, it's a lot easier to tell what's large bowel and what's small bowel based on these house tray. Now, intraoperatively, and something I was able to visualize during that colon resection last week really well, the large bowel contains what we call tinea. Tinea kind of are bands of connective tissue that sort of run parallel, and they're white, they're band-like, and they just sort of run the entire length of our large bowel. Now, the small bowel doesn't have that. The small bowel is a very smooth structure, kind of one color the entire way through, and using that can really help you differentiate where you're at, large bowel or small bowel, and ultimately help you gain a good sense of direction when you're in the abdominal cavity. And then there's one other thing that you kind of see on the large bowel. We get what we refer to as kind of fatty appendages, kind of plus or minus, but the large bowel, usually the whole way along, it has they almost look like skin tags, but tags of fat that kind of are attached to the large bowel. And the small bowel doesn't typically have those, but like I said earlier, we have this omentum that's kind of flapped and hung, suspending our organs and our vasculature in the abdominal cavity, and so that's really kind of subjective and kind of hard to see sometimes. So, like I said, I'll run through this one more time just to kind of give us an idea of where we're at. Right here we're talking about our cecum, so this is the beginning of our large bowel, innervated by greater splanchnic nerves from our thoracic spine and supplied with blood from the ileocolic artery, a branch of the superior mesenteric artery, which comes off of our abdominal aorta. We then move up our ascending colon, innervated again by the thoracic and lumbar splanchnic nerves, perfused by our right colic artery, which is, again, a branch off of our SMA. So we move along, we've got our transverse colon, perfused entirely by the middle colic artery, again, responsible for perfusion by the superior mesenteric artery, and innervated again by our thoracic and lumbar splanchnic nerves. So we move over, we work down our descending colon, turns at the level of the splenic flexure, innervated by the left colic artery, now being supplied not by our superior mesenteric artery, but our inferior mesenteric artery. This is, again, innervated by thoracic and primary lumbar splanchnic nerves. Move down to this atrociously drawn sigmoid colon. The sigmoid is supplied by our sigmoidal artery, a branch off of our inferior mesenteric artery, and again supplied by lumbar and partially, lesser and lumbar splanchnic nerves. We then move down to the level of the rectum, which we can also see over here. Once we reach the level of the rectum, we're really fed from three different arteries. We have our superior rectal or our superior hemorrhoidal arteries, the final terminating branch off of the inferior mesenteric artery. We also have our middle and our inferior rectal or middle or inferior hemorrhoidal arteries, being fed not now by our inferior mesenteric artery, but by branches off of our internal iliac arteries, which are a product of the bifurcation off our common iliac by, and then the other being our external iliac artery, which runs down the leg, supplies our femoral arteries, and are a topic of discussion for another time. Oh, and then innervation. Like I said, down at the level of the rectum, primarily our innervation is coming from pelvic splanchnic nerves, also hypogastric nerves, and we have a little bit of distal innervation by the pudendal nerve, both sensory and motor, or somatic. Somatic and motor are synonymous terms, responsible for contraction of the anal sphincter. So it's a good little review. I know it's messy. It looks messy when you're in there. But I appreciate you guys looking or not looking. Regardless, it's sort of a nice little refresher for me to sort of go through this stuff and draw it out. And I figure that the more I draw it out, you know, the easier it's going to be for me to identify it when we're in the OR. So appreciate it. Till the next time, and y'all have a nice night.